start, and I want to welcome everybody to our Wednesday evening webinar series. We're looking at the future of GI endoscopy, which this evening, which is a very important topic for all general surgeons, as a substantive number of procedures are performed by general surgeons, both upper GI and lower GI surgeons around the country. And there have been really significant advances in endoscopy over the last decade, particularly in terms of quality assurance and outcomes. And so I'm very pleased that we have Jan Leighton, who is the lead for endoscopy in the clinical programs, and Fiacre Cook, who is a colorectal surgeon in Waterford, who has been a strong advocate for improving standards in endoscopy amongst the surgical community. And our immediate past president, Ken Mealy, is going to lead out and chair the session, and I'm looking forward to a very interesting discussion. A couple of housekeeping notes: that if you are not actually presenting, then please do put your microphone on silent, otherwise we will start getting echoes and feedback. And do please, if you have questions, use the chat function in Microsoft Teams, which will allow us to pick them up, and Ken will introduce the questions at the appropriate time. We will have plenty of time for discussion towards the end. So Ken, over to you, and thank you very much.
Thank you, President, and good evening, everyone. Thank you very much for joining us. So it's my pleasure to introduce our two speakers and perhaps just give a little bit of background to this subject. Endoscopy, gastrointestinal endoscopy is hugely used around the country, and if you look at the 5th National Data Report published for 2019, there were nearly 250,000 endoscopy procedures carried out in, I think, 43 units in the public and the private sector in Ireland. Carried out by, I think, 736 different endoscopists. So a huge work activity in endoscopy. And if you look at the HYPE data for 2019, 144,000 endoscopies were carried out right across the country in all hospitals. And if you look at that workload, about half of the workload is carried out by surgeons, particularly in the smaller hospitals, and the other half is carried out by gastroenterologists, mainly in the larger Model 4 hospitals. So it's one of the few activities in medicine carried out by both physicians and surgeons. And I think there's a genuine interest by both physicians and surgeons that the quality of endoscopy should be high and should improve, because I think we're all aware of issues in the past where the quality has been less than ideal. There are particular issues with COVID. We also know in 2020, the 144,000 endoscopies reduced to about 104,000. So a significant, just under 30% reduction in endoscopy last year in the public sector. We don't know for the private sector. So clearly big issues in relation to capacity and how we provide an efficient service for the number of patients that require this service. We all know that quite a number of patients have unnecessary endoscopies, and that's a big issue, and perhaps the two speakers tonight perhaps can help us address how do we deal with that. Another issue is endoscopy out of hours. So if you look at the 144,000 endoscopies in 2019, 13.5% of those endoscopies were emergency endoscopies carried out following emergency admissions, may or may not have been within hours. So there's a huge number of issues that are of interest to all of us, surgeons and physicians, in terms of quality assurance, capacity, how do we manage that huge workload, and how do we engage with patients and provide an efficient service, understanding the huge volumes of patients that we're dealing with. So these are some of the issues that are of interest to me, providing an endoscopy service in my own hospital. And as I say, hopefully we will address these and other issues tonight with our two speakers. So the first speaker is, as you've gathered, Jan Leyden, who's a consultant gastroenterologist in the Mater Hospital. Jan is the national lead for the clinical program in endoscopy, supported by the HSE. So he's going to start the program tonight with an overview of the National Endoscopy Program and advances for the future. So Jan, over to you.
Thanks very much, Ken, and I'd like to thank Ronan for the invitation to talk to you today. So I've been in post since November, so in a way I'm still trying to hit the ground. What I plan today is to give you an overview of the program, what we're doing, what we're involved in, some of the new initiatives, and then a little bit on training. I can touch on maybe later about the out of hours and bleeding thing if we have time. Being a Luddite, I'm not very good at screen sharing, so Pauline's going to help me with the slides. So can we move on to the next slide, please? Pauline. So the program was established in 2016, and we have it comprises of an endoscopy lead and a program manager, a training lead, a nurse lead, and then we have an administrative person, and some of those roles are half-time. So we link in, we sit in acute operations and work very closely with Angela Fitzgerald and Liam Wood. So we're very good, very close working relationships with them. The main focus of the program is about delivering high quality endoscopy services across the country. We look at both maximizing capacity, trying to address manpower issues, and then governance, clinical governance of the endoscopy services in the various hospital groups. So we have, each hospital group has an endoscopy lead who we liaise through, and also obviously we touch base with the individual sites. In terms of capacity issues, we look at the current manpower, nursing, admin, endoscopist, manpower, the waiting list, the referrals, and the program has a very good working relationship with acute operations, scheduled care, the NTPF, the waiting list management programs, the Department of Health, Public Health, hospital groups, and obviously the RCPI and RCSI. So we've our finger in many pies, but it allows us to get a sort of an overview of what's going on nationally, and also we can access some of the data at a local level as well to see where there are pinch points. One of the key things at present is how we improve scheduling and validation of waiting lists, and trying to ensure that the right person is getting the right procedure, and trying to ensure that people who don't need endoscopy maybe can be diverted out into alternative pathways, but that if people do need endoscopy, that we'll try to address it, get them through the system in a timely fashion. Now, I accept that in the COVID era, waiting lists have doubled, and we're going to be really under a lot of pressure to deliver on the non-urgent waiting list, and we're under no illusion about that. And I'll talk in a little bit about some of the things we are proposing, or some initiatives we have to try and address this. The other thing we do is we try to support the development and expansion of bowel screen. Bowel screen is interesting. It sort of sits outside acute operations, and it's under the cancer control program. So we don't have direct, I suppose, operational view of it, but it's a very important program, and we're keen to support it. The next big thing, I suppose, that for me personally is the quality assurance and quality improvement. And I know Fiker is going to touch on this in the next talk, but the program is trying to support units across the country to get JAG accreditation, so that it's an international quality assurance accreditation for endoscopy services. This is an important benchmark, I think, for quality. It's not easy to achieve, and we're aware of that, but many centres across the country have achieved it, are engaged in the process. Obviously, at the moment, COVID has put things on hold a little bit, but all the screening centres nationally are JAG accredited. So we work on that in the background and support units in trying to get the JAG accreditation. And then we're in constant dialogue with JAG about issues that are, that arise about accreditation, and we're very aware that manpower and waiting lists are two problems that are recurring themes. The other thing that is the endoscopy quality improvement program, and one of the other hats I wear is I'm currently chair of the working group. So this is a pretty unique process or program, that we have every public endoscopy site in the country submitting data, quality improvement and assurance data. Sorry, I just dropped out there, I think, for a minute. And then we have 10 private hospitals also submitting data. So this is a framework that allows hospitals to develop quality improvement, and it's also a quality assurance tool. And I know FICRA is very involved as well, but I think this is very important in terms of how we develop services going forward, how we stand over the services we deliver, and how we improve the services. And then if we go on to the next slide, please. So as I said, we have the clinical lead, myself, half-time. The training lead is Professor Doherty, Glenn Doherty, who's half-time. And then we've Grace O'Sullivan, who's our program manager. And then we don't have a nurse lead at present, but we are in the process of recruiting again. And then we have an accreditation and training officer who looks after some of the JAG issues and also the training development. And next slide, please. So if we look at initiative for 2021, the program has been very fortunate, I suppose, that we have secured a significant amount of funding for 2021 and beyond. And part of that was driven by the COVID crisis and how we would have to improve services, address waiting lists, and work differently. And the three big initiatives we have are centered around triage and validation. So we're putting in 20 clinical triage nurses across the country in sites that don't already have them. These will be full-time CNM2s whose role will be in clinical triage, validation, supporting physicians and surgeons in the triage process. It's probably not envisaged that they would be standalone decision makers, but for some pretty clear-cut indications and referrals, they could definitely put patients in the right pathway. We're going to develop a suite of protocols to guide triage as well, and in line with the triage, we hope to get fit testing available on a national basis for symptomatic patients. So the plan would be that there would be a centralized lab that would process the fit tests, that patients could be triaged on the waiting list before they maybe even are put on the endoscopy waiting list. They could be triaged to have a fit test, and then based on the fit test results, they could be diverted either if it's normal or to clinic or alternative pathway. If it's high, then they could be diverted into colonoscopy. And we're going to use a very low fit test threshold. The current trial screen threshold is we're going to use 10, which is currently is probably the lowest accurate reading the systems can give. And at that level, they have a very high negative predictive value of about 98 to 99%, which is probably as good as colonoscopy. And then together with that, then those two, the fit and the clinical validation, I think will help us address the issue of how do you identify urgent patients and routine patients, and how do you identify patients who may have been referred for endoscopy, but possibly that's not the best option for them. There is a hope that we can use the fit testing then in maybe a one-off national initiative to address the long waiters related to the COVID backlog. And again, there will be a lot of work involved in the triage element of that. So we're hoping to have the fit testing online and available towards the end of the year. It has to go out, obviously, out to tender, and it's a whole new system and process we're setting up. And that the results will be available in the hospital labs, so that the results will come back to the hospital, be registered in the labs and registered on the patient record. Then the third thing that we're looking at is colon capsule endoscopy. So some of you may have heard of the capsule endoscopy, which is a small camera about the size of a large pill, which you swallow, and it takes multiple images that goes through the gut. So the colon capsule is a new development in this, and in the right hands it is very accurate and sensitive for picking up large polyps and significant pathology. There's going to be a significant training element around this, and we only have one or two sites in the country that are currently doing it, but we're hoping to expand that to 8 to 10 sites, around the country. So 1 or 2 in each hospital group. Again, there's going to be funding for this in terms of clinical nurses, the IT requirements, the equipment requirements, and the capsules. Now, this will take a bit of time, and the training in this takes a bit of time, but we hope eventually that this will be another non-invasive option for patients with low suspicion for significant pathology. We don't expect it to make a huge inroad into the long waiting, the current waiting list, but in the future, I think it will have a role, and it could even be expanded into the bowel screen service. But again, this is going to be a more, there's a tendering process, and it's unlikely to be fully up and running until next year, really. But we're hoping that these 3 initiatives, along with an increase in endoscopist manpower on the gastroenterology side, where we put in 6 new posts around the country, will help address the issues of underused capacity nationally, and get as many trained endoscopists providing services, and with their time, significant amount of their time focused on endoscopy rather than, say, general medicine or other activities. Can I have the next slide, please? So, as I mentioned earlier, my colleague Glenn Doherty is the national training lead, and he's been working on a new competency model and framework for endoscopy training in Ireland. So we have a working group comprised of surgeons and physicians and nurse endoscopists we've pretty much finalized the actual framework and how it will look. And this will be akin to the JET system in the UK, for those who are familiar with it, where there'll be a certain amount of supervised training and a minimum number of supervised endoscopy procedures you'll have to do, which will probably be in the region of 200. And then you will progress to a sort of a provisional sign-off where you're deemed to be independent for diagnostic procedures. And then there will be certain ongoing training and DOPS in therapeutic procedures such as GI bleeding, polypectomies, potentially enteric stenting. The framework doesn't involve ERCP and endoscopic ultrasound. You know, they're more advanced procedures. And the idea is that whoever wants to train in endoscopy, that regardless of whether you're a surgeon or a physician, that you will follow the same, or a nurse endoscopist, that we'll have the same training program with the same competencies and targets. We'll be able to deliver some of this online with new online courses. Some of it'll have to be hands-on, and we're looking forward to using the RCSI labs, which I believe are excellent. And then one of the other things we will embed into this training landscape would be sort of continuous upskilling for established consultants, and I know that FICRA was involved in one of the courses, I think, that we ran last year, and it was very well received in terms, you know, just that people who've been maybe a consultant level for a while can go on these courses and just learn some new tricks and tips, and I think it's important that we embed that into our model as well. So that is the vision of where we're going over the next year or two. And obviously, as I said, COVID and the waiting lists are one of the big issues that we all face. But I think in order to address the service, we have to ensure that we get the right people delivering endoscopy, and that we select the right patients and get as many of the urgent patients through the appropriate routines, and then we need to look at surveillance guidelines, and we're sort of trying to rationalize come up with a national set of surveillance guidelines for Barrett's esophagus, post-polypectomy surveillance, and bowel cancer surveillance, so and IBD surveillance. So that as well will be another element of the triage package that we're putting together. The issue of, I suppose, just Kenny had mentioned about the out of hours bleeding, and it is an issue nationally, and I know that in a lot of places it's the surgeons who have are left to sort of deliver the service, and maybe not all of those people who feel competent enough or are trained in it, and it is something that we will be addressing in the national gastroenterology and hepatology program. It is something we will we don't have a solution for yet, but I work in a unit where we have it's a 365-day-a-year consultant-led endoscopy service for out-of-hours urologists, and it is deliverable. And you know, if anyone who is interested wants to train in it, that can be done. And then obviously there may be issues about covering several sites or several hospitals, but I think going into the future, it definitely is an issue that will have to be addressed. And again, in the setting of competencies, and are people comfortable to do this sort of work in the middle of the night, and are they trained to do it? So that's sort of an overview of where we are, and I'm obviously happy to take any questions, but now or at the end.
Yeah, and thanks a lot for that. I was going to leave questions to the end, but I think there may be a question from Debbie McNamara. Do you want to ask now, Debbie, or are you happy to wait till the end? I take silence as meaning we'll wait till
I just wonder if Debbie's hand is up without actually accidentally, Ken.
So maybe, and I don't see anything in the chat function. So look, if you can hang on, I think it would make sense to have the discussion at the end. You've brought up so many different topics there, yeah, that we could spend hours talking about any one of them. And there's a couple of things I'd like to ask, but we'll leave it to the end. I think have both of you on a panel where we can address some of these issues. So thanks very much. And now we now pass on to FICRA Cook, who needs no introduction, I suspect, for this audience. Fikra is a consultant colorectal surgeon in University Hospital Waterford, and he's also the clinical advisor to the National Endoscopy Programme, the RCSI rep. So Fikra has been has demonstrated real leadership in terms of quality improvement in endoscopy for quite a number of times, and I welcome him here this evening and look forward to what he has to say. Fikra, have you shared your slides now with Pauline?
I think I have, Ken. Pauline, can you see the slides?
Fikra, no, you never sent them on to me. You said you were sharing them yourself there just before 6.
Lovely, then I shall do that.
Okay.
How does that look?
Yeah, we have you there, so over to you.
Very good. Okay, President Prof O'Connell, Mr. Mealy, thank you very much. Jan, it's a pleasure to share a forum like this with you. And as you know, myself, yourself and Ken have just come off the Endoscopy Quality Improvement Working Group meeting immediately before this. So I'm delighted to contribute my bit on this, or my piece on this. The title was for the surgical perspective on the future of GI endoscopy. It's a little grandiose, a little undeliverable in whatever time we have available to us today. But in terms of concepts, philosophies, where we think it's all going, what we think we can do from a surgical perspective, we'll have a look at that. Now, slides wise, can you see now? Have I gone from my first to my second slide?
You have, but it might be good if you went to screen show or slideshow.
Here we go. With the screen, or with the screen sharing, it may not play ball for me, Ronan. I'll work it this way. I'll work it this way. If there's any problems from a technical point of view, please let me know. A couple of observations are thoughts reflecting what's been discussed already as the burning issues, as far as I can see it, in the delivery of endoscopy, GI endoscopy, whether that's from a medical or a surgical perspective. I think we can get caught up on the who's doing it. It is a technical procedure that needs delivering, and that there's cross specialty nuances and skill set and sub-specialist input that can be very, very relevant from both medicine and surgery. So I will briefly talk about the quality side of things. The more broader philosophical questions of who's going to be doing it from a surgical point of view. You know, what is or who is the general surgeon of the future? Are we looking at an increasing number of exclusively sub-specialist surgeons performing GI endoscopy? And if that is to be the case, will lower GI surgeons not do gastroscopy? Will upper GI surgeons not do colonoscopy? We've mentioned as well the demand is greater than the resource can currently permit, and so nurse endoscopists are without a shadow of a doubt part and parcel of the solution. And again, whether nurse endoscopists would sit within the surgical or the medical side of the endoscopy unit will probably come down to the relationships in individual units. We look at training and accreditation. It's been mentioned as regards twofold, the training of trainees coming through both the gastroenterology SPR schemes, as well as the SPR programs in both general surgery, be that upper and lower GI, and how those processes are governed, managed, and with whom the ownership and sign-off will lie. But also accreditation for established and practicing consultants, and the maintenance of expertise or indeed competence, and what pathways will be open to us in people who fall short on their delivery of quality performance metrics. And then we look at sub-specialization, and again, it's stuff that Jan and Ken have already alluded to, the management of out-of-hours bleeding. Jan is playing down the achievement that they've reached in the matter, being, as far as I know, the only hospital in the country that has an out-of-hours GI bleeding rota, and I do understand that it's run entirely by the medics. I think that's probably something that is undeliverable in most places. There would have to be cross-specialist or cross-discipline collaboration for it to be both a medical and surgical discipline in a lot of units. Then the management of the complex polyp, we're seeing this brought into a sharp focus with the screening program, identifying complex lesions, sessile serrated lesions, and larger polyps for both EMR and endoscopic submucosal dissection. The wider availability, almost always out of hours, for stenting malignant large bowel obstructions, and then the screening program and the challenges and opportunities that the screening program is ongoingly showing us. The quality agenda, the quality improvement, quality assurance agenda is something that, as Ken has mentioned, I feel very, very strongly about and have spoken about on a number of occasions. This was the title slide from a talk that I gave to Charter Day back in 2017. And I think in the years that have passed since then, I think it's only fair to say that the acceptance, awareness, and participation with the quality improvement agenda has increased year on year. And I think if we look, as Ken also reflected upon, the national data report from 2019, I'll go into some of the data from that. It's an enormously powerful body of work and piece of data. And of course, it's very, very closely related and interlinked with the ongoingly updated guidelines for the implementation of the National QI Improvement Programme, which published its 6th edition to the guidelines back in December of 2020, as the national data report was published as well. So if we were to look at the national data report, the most recent publication is reflecting the data from the calendar year 2019. As Ken also mentioned, 44 participating sites, very, very powerfully across both the public and private sector. We had our update meeting just before we tuned into the webinar, where we have Q4 data from the 44 hospitals contributing for the end of 2020, such that we will have complete data for the calendar year 2020, which will of course reflect the huge decrease in activity that was brought about by the consequences of the pandemic. What is new in the 5th data report is that the hospitals have been de-anonymized, and I think that this is in every facet a positive move, in my opinion. And you know, it shines perhaps a sharper focus on hospitals where there's a perception of underperformance, but it is part and parcel, I think, of the direction of travel. And I suppose most importantly, the published upgrade to the guidelines in terms of some of the changes that have been made won't be reflected until the prospectively gathered data from 2021 onwards. So the national data report from 2019 is based upon the 5th version of the quality improvement data. So we see, as Ken said, 225,000 procedures generated or performed by 736 endoscopists. Some of the challenges around that, it seems an excessive number of proceduralists, but of course it takes into account both trainees and consultants. One of the challenges of interpreting this data is in fact that we cannot, as things stand, differentiate between procedures performed by a consultant versus that by a trainee, or whether or not that trainee was in fact supervised. And we see at the bottom of this particular slide that we're ongoingly performing not enough flexible sigmoidoscopies. I think that there's an excessive number of colonoscopy being performed relative to sigmoidoscopy. And again, a large number of OGDs. Ken made reference to the fact that we're doing too many procedures on probably the wrong people, and that there's a requirement, an absolute mandated requirement, as Jan outlined, in developing endoscopy services to triage people away from waiting lists for scopes that they don't necessarily need. The national secret intubation rate has been reached. The target is greater than 90%, has been reached for the last number of years. But it's interesting and a little salutary that only 73% of practicing endoscopists are meeting that target. And again, with the polyp detection, the national polyp detection rate of greater than 33%, is well above the standard, but 19% of endoscopists are not meeting the standard. And again, we're only measuring polyp detection. We don't have the capacity to benchmark the histopathology confirming adenomas versus non-adenomatous polyps in order to look at that as a more accurate reflection of pathology in terms of adenoma detection. Comfort remains the dichotomy, the balance between both comfort and the requirement for sedation and pain relief remains a challenge. But 87% of colonoscopies met the target for comfort in 2019. And again, sedation, the cutoff in terms of managing or being aware of one's sedation requirements is greater than or under 70. And that 79% of endoscopists are meeting the sedation targets in the over 70s. The bottom line here is again a figure that causes me some concern. 49% of endoscopists are performing less than 100 colonoscopies per year, as measured in 2019, and this is unfortunately this is a fairly consistent number. But again, in terms of interpreting it, we don't know whether those are perhaps trainees that move from hospital to hospital or move in and out of the system, or whether they reflect consultants in established practice with small volume practice. In terms of the changes in the National Quality Improvement Guidelines, we've changed. I was speaking offline with Mr. Mealy before we spoke. We've changed how we interpret comfort. The modified Gloucester Comfort Score is the benchmark of acceptability of the procedure for colonoscopy. It's not a validated method to interpret comfort for both sigmoidoscopy or gastroscopy. It is only validated for colonoscopy, and the measurement, the new metric, will be that greater than 90% of all colonoscopies will have a comfort score of 1, 2, or 3. Additionally, we do mention, or we do reference, the minimum number of scopes of 100 for the first time in the quality improvement guidelines, and we also make reference to a withdrawal time and a strong recommendation surrounding a withdrawal time of greater than 6 minutes for what will be deemed to be a scope where an intervention doesn't take place. So we look quickly at the sections with regards to the established targets, a cecal intubation rate of greater than 90%, an achievable target of greater than 95%, polyp detection, not adenoma, but polyp detection greater than 20%, comfort scores as we've mentioned, and then the median sedation and median analgesia requirements or delivery doses for both the under and the over 70s. The upper GI metrics would be retroflexion, successful intubation of the esophagus, retroflexion in the fundus, and then intubation of the second part of the duodenum, where the measurement there is greater than 95% of all gastroscopies. And then the new recommendations for best practice from the current guidelines are that we would look at a repeat gastroscopy requested for 80% or more of gastric ulcers, tattooing of suspected cancers greater than 60%, and then the incidences of adverse outcomes in terms of diagnostic perforations, post-polypectomy interventions, a 1 in 1,000 colonic perforation for a diagnostic procedure, and a less than 2 in 1,000 post-polypectomy perforation rate, as well as we've mentioned, that negative withdrawal time, the negative scope withdrawal time of greater than 6 minutes. We've mentioned the comfort score as well. I suppose one of the ongoing issues is the global acceptance and understanding of the comfort score. It's something that's clearly open to interpretation, but one of the strong recommendations coming from the program is that we would have a consensus comfort score agreement between the endoscopist and the nurses in the room. And as I say, that target has changed from version 5 to version 6, as we've outlined. We've also struggled with the concept of the photographic documentation in terms of cecal intubation, and I suppose not quite the completion of the procedure. The intubating of the cecum only, I suppose, allows one to begin the procedure. And again, this is a philosophical difficulty that is ongoing and outstanding. But the quality of the photographs that define that you have been to the cecum is something that is an ongoing challenge, and one which is suggested to be audited and reviewed internally, but can be quite a tricky chestnut. So I suppose the key findings are, as we've outlined before, there is still a large number of endoscopists performing small number of colonoscopy, and this remains a challenge. There's huge compliance within the target of cecal intubation. The quality of the photographic documentation around cecal intubation remains somewhat challenging. So we continue, I suppose, to look at these metrics. What is the goal, I suppose, of a national quality improvement program? Surely it must be about improving performance. And I think a couple of slides here will show how not only can you improve personal performance by maintenance, awareness, and striving to comply with national guidelines, you can improve your own personal performance. You can improve the performance of your unit, and you can improve the performance of the actual nationwide service. So if we look at data, this is NICWIS or NICWIS data for University Hospital Waterford from the time of electronic reporting, showing our colonoscopy in light blue, gastroscopy in turquoise, and in green sigmoidoscopy from the calendar year of complete data from 2014 on. We can see a consistent, relatively speaking, volume of throughput, which has been hampered by infrastructural limitations in terms of increasing our activity, and then this catastrophic dip in 2020 consequent to the COVID pandemic. But if you look at the various different metrics, this is my own personal data for 2014 through 2020 in terms of colonoscopy, showing year on year, metric by metric, an incremental continued improvement from electronic reporting starting in 2014 to 2020. The numbers you'll see have changed or fluctuated somewhat, but cecal intubation rate increasing in 2014 from 93% to 98%. My comfort scores dramatically improving from 2014 to 2020. Polyp detection rate going from 26 to 35, 37%, somewhat of a reduction for last year. And the numbers of diagnostic biopsies, as a measurable metric of performance, going from 96% to 100% over the course of the 6-7 years of data. We can reflect then on the actual unit as a whole. And again, if we look at colonoscopy for the department across all surgeons and gastroenterologists, we've increased our cecal intubation rate from 2014 at 88% to near 95% in 2020. Our comfort scores have incrementally improved, our polyp detection rates have improved, and our bowel prep quality have improved, all down to a departmental and a hospital-wide awareness, appreciation, and a striving to maintain and emulate the guidelines. And then if we look at the national data report from 2019, we see the very, very same performance reflected on a national level. So we go from 2016 through 2019, where across all metrics, cecal intubation, polyp detection, comfort, duodenal intubation, and midazolam usage in the under and over 70s, incremental, stepwise, year-on-year improvement. So to reflect on what a quality improvement program might be about, we've demonstrated that Ireland has a nationwide program across both the public and private sector that has delivered on raising the standard. And there's certainly plenty more work to do, but there's no question about it that it's going in the right direction. So I suppose the issue with such limited resources and such overburdened, if you like, demand, all the more complicated by waiting lists going off the charts since COVID. Jan very, very encouragingly mentioned the initiatives that are taking place across triage, across advanced nurse practitioners, across surveillance CNMs, the management of waiting lists through insourcing initiatives, are all part and parcel. And of course, the non-invasive diagnostics with regards to FIT and capsules are going to better triage, better screen the numbers of people coming through for assessment, and hopefully, I suppose, reduce down the number of patients appearing on waiting lists. And then the challenge will be to put the appropriate patients on the lists under the appropriate endoscopists in order for the procedure to be most meaningful. So I might go back, having done the quality improvement piece, and just reflect. I don't have significant answers about where any of this might go, but in terms of the discussion that needs to take place, who's going to be doing GI endoscopy within our own hospital? There's an increasing demand on the resource. How you kind of factor in vascular general surgeons, breast general surgeons, colorectal general surgeons, and GI gastroenterologists to a very finite resource. There's a major expectation in some respects that general surgeons ongoingly would have access to endoscopy, especially as they are the people who deliver the out of hours service. Interestingly, and this is something that Jan reflected on, but the out of hours bleeding chestnut, and it is a chestnut. We've looked at our data in Waterford over the past 3 years, and for 3 years of data, and I think it's reasonably robust in terms of its validity. There was 53 procedures performed out of hours over that 3-year period, and that's Saturdays, Sundays, and between 6 p.m. and 8 a.m. weekdays. And it's data that, again, with electronic reporting, is not that difficult to pull. But of that number, 53 out of hours procedures, 85% of them were done by the GI surgeons, and only 15 by the other on-call general surgeons. So it shows as to who's doing the out of hours stuff out with an actual out of hours rota. The management of complex polyps and stenting and I suppose screening are again wider issues that are going to be looked at and need to be discussed. And then the issue of training and accreditation. Jan obviously took over from Chris Steele, but Glenn Doherty, who was on the ticket tonight, who was standing in while Jan was substantively appointed to the National Clinical Endoscopy Programme lead, has taken over as the National Training Lead. And again, along with the team of people around him, Dorothy Murray in the college and Grace O'Sullivan and the people in the National Clinical Programme, there's a suite of initiatives around training and accreditation and upskilling. So there's an awful lot of work being done behind the scenes. What I would say is that participation and involvement and engagement with the programs are crucially important. And I think the real gains are going to be around a higher standard across the board for people doing endoscopy. And that there would be mechanisms in place, I suppose, for underperformance or low volumes or excessive complications or post-colonoscopy cancers that would be acceptable and acknowledged and universally agreed, such that we have a mechanism in place to manage underperformance, if you like. The other piece then would be engaging with the GPs, and a huge volume of work is required, in my opinion, at selling the newer paradigm of investigation and management of GI pathology to the general practitioners, such that the expectation of referring for scopes is reformatted, it's rebranded, and despite an awful lot of work locally, there's still a huge number of what I would deem inappropriate referrals coming from general practice. There's also a huge amount of inappropriate patients ending up on surveillance waiting lists. But again, part of the expanded CNM appointments coming on stream will be for surveillance and triage. And I think there's a huge amount of work is going to come out of that, a huge amount of benefit is going to come out of that in terms of reducing down numbers on waiting lists. The issue around surveillance, again, it can only come from awareness and understanding of the program, but there's very strong, robust guidelines have been issued with each of the publications of the National Quality Improvement Guidelines, and the appendices at the back reference the management of the surveillance of polyps, of cancer, of Barrett's, of colitis, the management of anticoagulation and antiplatelets coming from procedures. And again, it's a message that can't be hammered home often enough, such that the general standard of understanding and appreciation of what we're trying to deliver is raised. So I might leave it there, Ken and Ronan and Jan, and I'm more than happy to respond to questions or to be questioned on anything that has come up, and leave it at the questions and answer session for now.
Great, Fikra, thank you very much. And perhaps you could just stop sharing your screen so that then we can see the speakers as they come up. Okay, can I start the ball rolling by asking Jan maybe something that hasn't come up tonight, and it's something that you see a fair bit in the American literature and does have an implication then for capacity. The whole issue about CT colonoscopy. There's a lot in the American literature at present, and conflicts between gastroenterology services and radiology services. Do you think it has a role in terms of dealing with capacity, and do you see that there could be competition in the future between radiology services and gastroenterology services in providing colonoscopies?
It definitely has a role. I don't see any conflict personally. We're very lucky here in the Mater because we had some people who were involved in the early days of CT colonography. So it's a great resource to have. Unfortunately, not every hospital has people trained in it. I think CT is a very valuable resource in itself. So that's one of the challenges, is how do you get into it? But you know, I'm very lucky here. I can ring up CT for a failed colonoscopy, and I can have a CT colon 9 times out of 10 done the same day. What we're looking at in future, maybe in some sites, is that the colon capsule would replace that. But I think the volume of work is such that there's no threat. And I think actually CT colon is a better test for the patient with abdominal pain and weight loss as the initial test, especially the older patient, than a colon, you know, with no other altered bowel habit or bleeding. You know, it gives a lot more information maybe than the colonoscopy. Now, selling that sometimes is a tricky thing. It involves less prep, it's less risk to the patient. You know, there's a lot of benefits to the CT colon, and I do think it needs to be considered more. Okay.
And the other issue I wanted to ask you about was, and Fikra also brought it up, in terms of out-of-hours services. There's a considerable amount of literature showing that mortality from bleeding peptic ulcers, and certainly from variceal bleeding, remains really stubbornly very high. Do you think there's a role for a national retrieval service and managing these really problematic patients in 1 or 2 centres around the country? Now, I know they need to be stabilised, but you know, if you have somebody with a variceal bleed working in a smaller hospital, you know, the number of patients seen on an annual basis would be very small. So would you see that as part of the sort of network planning that you would see in the future?
Yeah, and we've been talking about this. We're looking probably at a hub for the variceal bleeding at a hub and spoke model. With, unfortunately, St. Vincent's is inundated with patients with variceal bleeds, of patients who will never get to transplant. So we would like to see that, you know, CUH, Mater, Bowen, Vincent's, Galway would be bigger centres that could take bleeding once they've been stabilised. Now, like anything, it's about capacity and building that capacity. But you know, the bleeds happen. Most of them can be managed relatively straightforward. They don't need to go to St. Vincent's liver unit. Most of them never need to go near there as a first point of call. Bleeding stabilization is, you know, there's good literature. It has to be done within the first 12 hours, not immediately. So that, you know, resuscitation saves lives, and then you do the procedure. So we're working on that model. The endoscopy program, I've been tasked sort of to look at that by the National Endoscopy clinical program, and also linking in with the liver centre. So that's where we're trying to aim for. And then I think in hospital groups, we're probably looking at some sort of whatever arrangement works for the groups. Is a cross-site cover. Cross-site cover for bleeding can be difficult in terms of people are going into centres that aren't used to and serve places. Surgeons, maybe some surgeons are more used to it. We're not used to going into other centres, but I think arrangements can be made, and they have to be made. We're sort of, it is a gap in our service, and if you look at the UK, they're way ahead of us on this.
Okay, there's a comment here from Paul Balfe about endoscopy suites only being open 9 to 5, Monday to Friday, and perhaps hours to be extended. But I guess the issue there is most hospitals don't have enough whole-time equivalents in terms of endoscopy and support staff, so it's a real staffing issue. The President has a comment here. Is there a role for triage using electronic referral pathways, I think perhaps you're referring to? And I think that's part of what you're talking about, isn't it, Jan? That there will be very structured care pathways with defined criteria that patients need to satisfy to fall into the different channels of direct access, for instance.
Well, one of the things we're looking at, and it involves HealthLink, and HealthLink has an endoscopy referral module. Now, unfortunately, I want to sort of work with that to have a minimum data set, and so the aim would be to get HealthLink as the mechanism to refer in, and that we can get fit testing and calprotectin available in the community. At the moment, you can order a colonoscopy, you can refer somebody for a colonoscopy without even doing a full blood count on them, which in a way is a crazy situation. You're putting someone into an invasive investigation and you haven't even taken a blood test. So if we have a minimum data set and we can get these services available to the primary care, along this launch of care model, I think it'll just streamline how we refer people in.
Okay.
And I think if I could come in on that, Ken, the additional broadening of the team in and around the delivery of endoscopy to include the kinds of appointments that Jan has mentioned, the CNM2s in triage, surveillance, and advanced nurse practitioners. These are going to be crucial people that will be the first point of contact for this kind of an electronic pathway, and will screen through a very structured triage process. And again, I suppose one of the most important things is that they will have a mechanism of reporting back to the referring clinician, be that the GP or somebody within the hospital, that this referral does not fulfill the criteria for X, Y, or Z reasons, and it puts a formal structure on what might be deemed an inappropriate or an underworked up referral.
I think that whole concept of having standardized referral and follow-up processes and having triage CNM2 nurses, I think probably offers huge opportunities. That's very manageable in the near future, and as such is very modest cost in terms of standardizing what we do and rationalizing what we do. I think we're all very much aware that so many people, I often carry out endoscopy lists for patients from other services, and I wonder, why are we doing these in many cases? And I'm sure that that's an experience of many of you. We have a comment here from Saiji Ali about, is there a training program for Nchd doctors? And I think one of the issues is that if you're on a formal training program, whether it be higher specialty training in gastroenterology or higher surgical training, yes, there is a formal training program as part of your training competencies, but there isn't for those non-consultant hospital doctors not on formal training programs. I don't know whether you want to comment on that, Jan, because it is a huge issue, isn't it? And perhaps with the competency frameworks that you're putting in place, there will be room to allow those doctors not on formal training programs to get accredited for training in that regard. Am I right in saying so?
Yeah, well, our vision would be that we create the competency framework, and there are targets and metrics to be met, and the challenge is having the trainer and somebody to train you and sign off. Yeah, no, our feeling would be that if somebody wants to train in endoscopy, this will be the common mechanism. So that's what our vision would be. Obviously, it'll be easier for people in the standardized training programs.
Okay. So another comment from the President: does the National Endoscopy Quality Improvement Programme include the private sector? Well, it does. Of the 44 hospitals, 9 of them I think are private sectors.
We have 10 at the moment. 10, yeah.
And again, this is one of the few initiatives that cross the public and the private sector, and I think it's very welcome. Comment from past President Declan McGee: to what extent does the issues arising from cervical check audit impact on the changes in approach to CIR photo audit? Well, that's a really good point, I guess, and it was a question I was going to ask Fiacre in terms of the KPIs and auditing the KPIs. I think in my own hospital, we're one of the few hospitals that actually carry out audits of all endoscopists' KPIs. The KPI for cecal intubation is a self-reported audit, and or it's self-reported. So the unit I work in, the clinical lead takes out 20 consecutive colonoscopies for each endoscopist twice yearly, and looks at the various cecal intubation markers, terminal ileum, ileocecal valve, triradite fold, and appendix orifice. So I don't know whether anyone else is doing that, but Fiacre, would you like to comment on whether is that necessary, do you think, or are we just being a little paranoid here in my own unit, or do you think that's something that has merit in all hospitals?
Ken, it has enormous merit. You know, clicking a box to say that you've been to the cecum with no photograph on file to support that is just, it's shocking, and I think it's something that is very difficult to stand over. You are a shining example in Wexford of the actual cecal intubation photographic audit that you continue to run. It's extremely labor intensive. It is not straightforward to do. It can be something that can be a little thorny and tricky, as Declan refers to, and I know that we've spoken about this over the years. So it is absolutely mandatory, in my opinion, that the quality of the photograph reflects the landmarks or the level of the colon that's been reached, and in somebody who consistently ticks the box to suggest that they've been to the cecum and does not have photographs to back it up, there's a major problem. There's a major problem. But in fact, the governance around that and the management of the audit and the manpower involved, as you well know, is by no means insignificant.
Well, I suppose in reply to Declan, there's no reason why any hospital could not engage in that in terms of defining the quality improvement process that they want, and the quality assurance to back that up, and engage in an audit like that if that is supported by the governance structure in that hospital. So it does involve a bit of work, but it not as much as you might think, but it clearly needs buy-in from everybody, as you know, but is manageable. Okay.
On that, part of the problem was that the NICWIS has no mechanism to receive that type of photographic data audit, so we can't adjudicate on it. And if you look at our colleagues across the water, in the UK, they have a very sensible thing about a documentation agreed in the nursing record of cecum being reached. And actually, the most sensitive, I think the most sensitive marker of an endoscopist's ability is if you take the endoscopy nurse out of the room and ask her, okay, what's he like? And you will get a very quick answer.
I'm sure that's right, and certainly in our unit, I insist that the nurses define what the comfort score is, for instance. I don't think there's any purpose or point in the endoscopists themselves doing that. But I guess you could say that in regard to clinical practice everywhere. Ask your nurse colleagues if you want an honest answer about the appraisal of any of us in terms of our technical skills. A comment here from Camilla Carroll regarding ENT urgent care and using HealthLink as a driver. I think this is all for the future and particularly in relation to Strontia care. I think we're going to have these electronic pathway referral processes in the future, and for most of us they won't come soon enough, I don't think. A comment here from Adrian Ireland: how are we to audit the withdrawal time for negative colonoscopy? Our ERS does not record this measurement.
Which ERS? So some ERSs don't record it on the actual report, but in the database behind it, everything is recorded. So when a lot of these reports have a like Endorad, which I use, there's a huge database that is recorded behind it, and you can go in and all those things are available on it. Some people do by the other options. You take a photograph. Again, these are things the endoscopy program and the quality improvement program are addressing, and there will be a new tender out for nationally. We're looking at the upgraded endoscopy reporting systems, and the new systems should be able to, hopefully, any new system should be able, our upgrade of a system should be able to provide this.
Yeah, I might come in as well just to reinforce what Jana said. On Endorad, which is probably the most commonly used electronic reporting system countrywide, you obviously must hit start withdrawal time, and then you obviously hit your procedure completion time at the end, and furthermore, so that's one method of defining your withdrawal time. The second, and I would agree with Jan, is to have your photograph of your cecum at time point X, and then your retroflexed view in the rectum immediately prior to finishing at time point X plus at least 6 minutes. So again, there's work involved, but it's it's doable robustly and repeatedly via at least two different methods.
And an interesting point here from Syed Ali again: ascending colonic retroflexion should be added as part of standard colonoscopy, as there is an 8% polyp missing rate. Have you any strong feelings about that retroflexion in the cecum?
I do. I think you need to be a very I think you need to be a very competent endoscopist. You need to be probably using pediatric colonoscopes, and you need to know whether there's capacity to do that. So I wouldn't. If you look across the UK introduced I think it's called the Quick study, where they have a package of procedures, and I think 5 or 6 things, and one of them was retroflex in the cecum, put the patient on their back in the transverse colon, Buscopan, and greater than a 6-minute withdrawal time, and that alone increased polyp detection. They didn't have to do anything else other than that. So I think it is a technique that has definite merit, but you need to know your patient, your skills, your scopes, and I wouldn't be.
I'd agree with Jan, and I would further reinforce that probably patient position is appropriate. Anatomical specific patient repositioning is more deliverable, and interrogating the cecum in the right lateral position and the ascending colon in the left lateral position with a different perspective both on insertion and withdrawal are probably going to give better yield than retroflexion in the cecum, which is probably going to be very challenging and perhaps associated with discomfort and an increased complication rate.
Comments here from Assam Ishtiak: maybe we need to move towards keeping digital records of all endoscopy procedures, as all systems allow for digital recording, and then taking timed photographs. I guess I'd say in response to that, being a person that audits all my colleagues, consecutive colonoscopies as part of our biannual audit, I'm intrigued because within 2 seconds, looking at a report, I can actually tell who the endoscopist was, because we have a couple of very high quality endoscopists, and within a couple of seconds, I know, by not looking at the name, but looking at the photographs and the quality of those photographs, who the endoscopist is. So I think taking appropriate photographs is one of the ways to go. And if you take appropriate, good quality photographs in the cecum, the chances are the rest of that colonoscopy is going to be good quality as well. So I guess one gets confidence, and we all have that in terms of knowing our colleagues, looking at these photographs. Very quickly you become confident looking at these in terms of the quality.
And Ken, the single marker of quality is actually the polyp detection rate. That is the one that's most validated. And if you're thorough, you'll have a high polyp detection rate.
And I guess something you actually said in your talk, Jan, was that it's not just the polyp detection rate, but it's the adenoma detection rate, which we haven't got that far yet. But I guess we need to get there, because I suppose loads of us could be removing all sorts of small multiple hyperplastic polyps, which are of no significance, but it's those adenomas that are important. Those are all the comments I have here. I think we've had a fairly interesting discussion, touching on a lot of the issues which clearly are pertinent to many of the listeners here. The whole issue about endoscopy quality, I think, is important, and it's going to remain important. It's one of the few areas in technical medical practice where we have a visual record of what we do. And I know that there will probably be trends in the future, for instance, for all operations to be video recorded, because that's the world we live in. And I think that the digital record taking that we have for endoscopy and the measurement and management of that is going to become more and more important in the future. And I think there will be an onus on all endoscopists to demonstrate that they are competent and maintaining their competence by talking about some of the things, by involving themselves with some of the things that we're talking about here. Any final comments from either of our speakers, Jan, Fiacre?
I'd like to thank Professor O'Connell and you, Mr. Mealy, for curating, for putting together the webinar, and for giving me the opportunity to talk. I have been hugely encouraged and massively impressed by my involvement and my participation in the quality improvement agenda around GI endoscopy, and I do think it's a massively powerful movement that we can look at the kind of data that we collect for, as you say, almost 250,000 procedures performed by over 700 proceduralists on every publicly performed colonoscopy and a large percentage of the privately performed endoscopy in the country. So this is a program that is a shining example of quality improvement agendas, and as I've demonstrated, it is immediately able to demonstrate improvement in people's performance and in the performance of the service.
Fiacre, thank you very much.
Thank you, Ken.
Jan, thank you very much for joining with your surgical colleagues tonight and giving us your insights into the national programme and what the future holds. I'll hand back now to the President to wind up the meeting.
Ken, thank you very much, and thank you to our speakers. I'm just reflecting, we've come a long way, certainly in my lifetime, from the GI unit in Sir Patrick Dunn's Hospital and Donald Weir, and coming out with the black eye, having looked down the endoscope, and how things have progressed. I think it is so impressive, the benefits of audit and quality improvement, and I have no doubt that this will be a template that can be extended into other procedures, not only within the GI sphere, across surgery. And I think, Fiacre, your demonstration there over the 7 years of year-on-year in quality improvement. The problem is, what are you going to do when you get to 100%? Because then the only way is down. But I suspect you'll continue to excel. Thank you all. I hope all who've listened in have enjoyed the evening, and I look forward to seeing most of you next Wednesday. And thank you, as always, to Pauline Lyons in the background, and to the Vice President Laura Vianney, who has put together the programme for this semester. So good evening, and thank you all.
Thank you.
Thank you. Bye now.